Welcome to the National Coalition of 100 Black Women Dallas Metropolitan Chapter's webinar, Healthy Heart Health for Sisters. Welcome, welcome, welcome. I'm Charlene Powell, Health Committee Chair for the National Coalition of 100 Black Women, the Dallas Metropolitan Chapter. We're happy to have you join us this evening for what we will believe will be a very informative and empowering program. As February comes to a close, we celebrate Black History Month and also Heart Health Month. Tonight's program is a combination where we have the opportunity to promote both cultural awareness and wellness in the lives of Black women in our area. Thank you again for attending, and at this time, I will turn the program over to our president, Sonia Irby. Madam President.
Good evening, everyone. And thank you all for joining us tonight for this important discussion on heart health. I do want to take this opportunity to share a little bit about our organization for those of you who might be joining us for the first time and may not be familiar with our organization. But the National Coalition of 100 Black Women is a 40-year-old advocacy organization. And our mission is to advocate on behalf of Black women and girls to promote leadership development and gender equity in the areas of health, education, and economic empowerment. Our vision is to see Black women and girls live in a world where socioeconomic inequity simply does not exist. And that includes in the area of healthcare. So we're excited to have you with us tonight. You are tuning in to the Dallas Metropolitan Chapter's event tonight, and our chapter was founded in Dallas in June of 2018. And we are here to advocate on behalf of the Black women and girls in our area who may or may not have a voice in this arena. So we thank you for your support. We thank you for those of you who will continue to support us beyond this event. And we ask that you listen in intently, ask your questions, and we hope that you enjoy tonight's program. Thank you.
Our session this evening is focused on heart health, specifically for Black women. And today we will learn and find out ways that we can advocate to find out about the triggers of heart disease. How do we recognize those symptoms of heart disease? And what is the impact of genetics and strategies that we can use going forward to affect change? This is information for our participants, and we hope that you will also share this information with your family and friends. Nicole Crooks, who will provide our introduction.
All right, good evening, everyone. Like she said, my name is Nicole, and I have the honors tonight to introduce to you our wonderful speaker, Dr. Shauna Nesbitt. Shauna D. Nesbitt, MD, MS, is a professor in the Department of Internal Medicine at the University of Texas at Southwestern Medical Center here in Dallas, Texas. She is the medical director of the Hypertension Clinic at Parkland Hospital. Dr. Nesbitt earned her medical degree at Hahnemann University School of Medicine in Philadelphia, Pennsylvania. After an internship and residency in internal medicine at Allegheny General Hospital in Pittsburgh, she underwent fellowship training in hypertension in the Department of Internal Medicine at the University of Michigan Medical Center in Ann Arbor, Michigan. Additionally, Dr. Nesbitt earned a Master of Science in Clinical Research Design and Statistical Analysis from the University of Michigan School of Public Health. She is board certified in internal medicine, and she is a fellow of the American Heart Association Council for High Blood Pressure Research and a fellow of the American Society of Hypertension. She is a certified hypertension specialist. In addition, she is an alumnus of the Executive Leadership in Academic Medicine program. She is an alumnus of Health Executive Diversity and Inclusion Certificate program. She is a former president of the ISHIB, or International Society of Hypertension in Blacks. And she is also a current board member of the Southwest Affiliate and the National Scientific Advisory Committee of the American Heart Association. She served as a member of the Clinical Trials Review Grant Study Section for NIH NHLBI. She is currently a member of the Observational Study Review Board for the Jackson Heart Study sponsored by the NIH-NHLBI. Her research interests in clinical trials in hypertension and cardiovascular prevention. She has served as a national leader in hypertension clinical trials with a special focus on pre-hypertension, hypertension in African Americans, and healthcare disparities. She is currently a site principal investigator for the ASPRE clinical trial. She is an active clinician as well as the medical director of the hypertensive clinic at Parkland University. She received the Women Who STEAM Science, Technology, Engineering, Arts, and Math Award in 2019 from the Dallas chapter of the Links Incorporated. She was also named a 2016, 2017, and 2018 D Magazine Best Doctor. In 2023, she was honored with the Lower Lifetime Achievement Award by the American Heart Association and the Woven Healthy Lives Committee. In addition, in 2023, she was honored by the C.V. Roman Dallas chapter of the National Medical Association for her efforts to increase the workforce of minority physicians with the scholarship in her name. For 11 years, she served as Associate Dean for Student Affairs in the Office of Student Diversity and Inclusion at the University of Texas Southwestern Medical Center. She led the team at the medical school, graduate school, and School of Health Professions that focused on efforts to recruit students from diverse backgrounds and to create educational programming that supports an inclusive environment, preparing students for careers in science and medicine. She is active in guiding education for the medical school and cultural sensitivity and approaching diverse patient focus on creating equity in science and medicine. As of October 1st, 2022, after a national search, she was selected as the inaugural Vice President and Chief Diversity, Equity, and Inclusion Officer at UT Southwestern. She currently serves as the inaugural Chief Institutional Opportunity Officer at UT Southwestern, and as of 2024, she is the holder of the John C. Vanetta III Professorship in Medicine. And with that, I will turn it over to our wonderful speaker this evening so that she can bring forth this wonderful education for us.
Thank you so much, Nicole. That was more than necessary, and I really appreciate the opportunity to meet with you all tonight and share my thoughts around how we can be healthier for each other, to promote the purpose that we all are here to provide for our families, for our world, for our country, to be better as a people. I will share my screen and walk us through our conversation. And as we complete the conversation, I hope you'll have some questions that we can talk a little bit about things that you are burning to know about how to live a healthier life and be free of heart disease. And so let me start by giving you my why. Why do I do what I do? Because I think it's important for people to have a why you do what you do, because that is just as important as what you do. I grew up in a family in Pennsylvania, and my father came from South Carolina. As a child, my father's mom died very, very early. She was just approaching 60 years old, and I was just 2 when she died. She died from heart disease, from heart failure, because in her lifetime, she lived in South Carolina, where cardiologists would not see Black women. They wouldn't see Black patients, period. So in order for her to be seen, she had to get on a bus and travel to Cleveland, Ohio, to be seen at the Cleveland Clinic. And obviously, from meager means, that wasn't very possible frequently. Seeing a doctor once a year just is not enough. And she died very early in her life. And that affected me, even though I never really got to know her very well. I look like her, but based on the pictures that I've seen, but boy, how much you miss from not having the warmth and guidance of a grandmother who can really help to shape your life. Fast forward to just 3 years ago, my sister-in-law passed away from sudden cardiac death at exactly the same age, and her grandchild was yet to be born at that time. that made me reiterate how important it is for us to maintain focus on how we take care of ourselves, how we advocate for each other, and how do we change this problematic epidemic within the space of Black women in particular. So as I thought about what I wanted to do, I have always wanted to make sure that I was purposeful in affecting people who look like me and people who suffer from the same things that my family has had to deal with. So with that, let me share my thoughts around heart health. Cardiovascular disease in America is a pervasive problem, and 50% of all adults between 45 and above will have some form of cardiovascular disease, whether that's hypertension, coronary heart disease, heart failure, or a stroke. All are manifestations of vascular disease in some capacity. And remember, the circulatory system is all connected. Adults between 60 to 79 years old, 77% and 75% of women have cardiovascular disease. And over the age of 80, 85, and 90% actually suffer from cardiovascular disease. And so technically, if we all live long enough, we are going to have some aspect of this that touches us, if not yourself, someone that you know and love very well. If we look at the causes of death divided by gender, males on the left and females on the right, the leading cause of death is heart disease for both men and women. And it surpasses cancer and other causes. And within cancer, obviously, we know that there are many different causes of cancer. For women, in particular, would be breast cancer and some lung cancer, but heart disease is still number one. If we look at the map of heart disease in women, specifically over the age of 35, the very darkest area of red that you see are the very highest rates of heart disease by county. We live in one of those counties where heart disease is at the highest risk. 1 in every 5 females is going to have heart disease, and 1 in every 16 is going to have coronary heart disease. And so if you look at that by race ethnicity, 6% of whites, 6% of blacks, 6% of Hispanics, 3% of Asian women. That I want you to recognize, because it's often said that women don't get coronary heart disease. Women die from breast cancer and other things. Not that we don't have those other things, but we certainly have heart disease. And one of the reasons that that is perpetuated is that our symptoms are a little bit different than others, and it frequently leads to those symptoms being missed. Chest pain is what we call angina, can manifest as dull or heavy pain in your chest that can be indolent, meaning it just sort of slowly comes on, or it can be sudden. More often for men, it is described as an elephant standing on your chest. It's a very sharp pain. That is the way that it is taught in medical school. It's the way it's taught in nursing. And so people are looking for that major manifestation in order to believe that this could be heart disease. But in truth, more commonly, what women observe is sort of a more subtle presentation of pain in the neck, the jaw, the throat, maybe even in your shoulder, upper back. And we might assume that that is indigestion or that it is esophagitis, nausea, vomiting, just plain old fatigue, dizziness, fluttering in your chest or palpitations, shortness of breath, and then some swelling of the legs and ankles might tell you that you might have heart failure, or the heart not being able to appropriately serve blood to your entire circulatory system as is required. All of these symptoms are possible. You don't necessarily need to have all of them. You may have only 1 or 2 of them, but it is key that we know that so that we can advocate for ourselves to have the proper testing done to make sure that it isn't missed. Coronary heart disease is one component of heart disease overall, and that is diseased blood vessels on the surface of the heart that serve the muscle of the heart. I'm going to show you what that looks like in just a few moments here. But if we look at this map of coronary heart disease, specifically Texas, in Texas, over the age of 45, about 10% of people have some aspect of coronary heart disease. If we look at more broadly, if we think about cardiovascular disease, that is heart disease and stroke, what are the most common risk factors for that? Among the list of risk factors is high blood pressure. It is highly prevalent in the country, period, but even higher prevalence among Blacks. 68% of all individuals who have heart disease and stroke will be taking blood pressure medicines in the state of Texas. And if you look at this map at other states, we are amongst the highest. If you look towards the darker blue states, that is the Southeast, somewhere around 75% of the individuals in those states are also taking blood pressure medication. That's important because this is a risk factor that we actually have control of, and I think we need to be more vigilant as to what it means for us and how we can prevent the progression by simply managing that one risk factor. I talk about coronary heart disease. Well, what exactly is that? It is blockage of the blood vessels on the surface of the heart. And you're looking at the heart on the left. The blood vessels on the surface are the blood vessels that serve the muscle, because the heart is one big muscle with a cavity in the middle. If you cut those arteries in half on the right side of the slide, what you see is the very first tube is showing you what should be happening, blood cells flowing through that blood vessel freely. As we develop atherosclerotic plaque, and that happens as we get older from about age 15, you see this yellow plaque developing in the wall of the blood vessel. The bigger the plaque, the tighter the stenosis, until the point where it touches itself, which means that you can no longer get blood through that blood vessel to serve the muscle of the heart. That's what we call a heart attack. When a heart attack happens, you don't have blood flow to the muscle dies. And so on this picture, you see a purplish area, and that's because that blood vessel in the circle has been blocked off, and all of the areas that would have been supplied by that one blood vessel will die. What happens then? That's when you develop what's called heart failure, because the heart can no longer beat efficiently to get the blood from the inside to the outside through that big blood vessel here. That's the aorta that serves the pathway for blood to go to your brain or go to your other organs of the body. So it is critical that this very small blood vessel on the surface of the heart, these multiple blood vessels, be taken care of well. Now, so the yellow that you see developing in the wall is atherosclerotic plaque. That develops largely from cholesterol, but it's not just cholesterol alone. So as you start developing it in the wall itself gets damaged. The plaque embeds itself into the normal wall. And then as we get older, it gets calcified. And as it gets calcified, now it's hard. And so it's immovable. This is what we are looking for when we do a CT angiogram, that we're looking at coronary calcium burden. We're looking at that calcium deposition in blood vessels all over the heart. The amount of calcium that you have is a signal to tell us how much blockage you have already developed in the blood vessels in the heart, which is a way that we assess risk. Now, I spoke about heart failure. And so heart attacks and heart failure is not exactly the same thing. A heart attack is, as I say, not getting enough blood flow to the muscle, and that part of the muscle dies. It may cause you to develop heart failure. However, you can have heart failure without having a heart attack. Heart failure, again, is when the heart is not able to efficiently pump out blood. And so what does it look like on a chest X-ray is that, as opposed to having sort of a black appearance of your lungs, meaning that the lungs are clear on the outside of the heart here, you have this butterfly pattern of whiteness on both sides of the heart, which indicates that there's fluid backing up into your lungs because the heart can't push it out to where it's supposed to go. The symptoms of that are shortness of breath. Your blood pressure may drop low. At night, you'd have difficulty laying flat in bed. You may feel like you got indigestion because you don't breathe well. Your ability to do what you are normally doing slowly declines, and it also shows up usually with a fast heart rate as well. Other areas of your body may change, is that swelling in your ankles and feet is a common phenomenon, and that swelling, once it becomes more pervasive, can also be in your hands. On the inside of the heart, what does a heart attack look like? A heart attack looks like this, and I know it's not a beautiful picture, but it is accurate. If we cut away the surface of the heart and look inside, you're looking at muscle tissue, and this darkened section here that's sort of a dark gray color is the place where the heart has been damaged because of the blood flow being blocked on the outside of the heart. And this section here is a place where you see the tissue is actually even split away from where it should be connected, which adds to the dysfunction of the heart's ability to pump blood forward. So how do we prevent that? Risk factors that we need to know. A, cholesterol. Your cholesterol needs to be on total cholesterol less than 200 LDL. That is the bad cholesterol, or the most atherogenic, sticky kind, should be ideally below 100. Smoking, don't do it. Don't do it. Just don't. There is nothing that's going to be good for you about smoking cigarettes. Diabetes. Got to control the blood sugar. The blood sugar being elevated elevates your risk in so many ways. Diabetes very connected to obesity. In America, more than half of all diabetics are obese. And when I use the word obese, I mean they are above the ideal body weight of 30 BMI. And controlling the blood sugar clearly lowers the risk. High blood pressure. We're going to talk about what the right numbers are for your blood pressure. Again, a very pervasive risk factor, especially among Black women and Black men, not as well controlled as we would like to see it. Physical activity. Increasing your physical activity has a significant effect, and having low levels will certainly increase your risk. High diet in carbohydrates and fats, obviously another risk factor that you control. The things we can't control: age. We can use Botox and all kinds of things to look more beautiful, but we're still going to be the same age. Gender, yes, you can transition, but that doesn't necessarily affect your risk for heart disease. And then knowing your family history, very important, because it helps you to be more prepared to think about this as you are talking to your doctor, wherever you are, and whomever that doctor may be. So let's come back to blood pressure. What are the right numbers to know? The most current guidelines are this table here, is that normal blood pressure should be below 120/80. That is the perfect ideal. We are happy when people who have hypertension can keep your controlled blood pressure below 130 as a systolic and 80 as a diastolic. That is the goal of your blood pressure treatment if you already have hypertension. We diagnose hypertension at 130/80 in the presence of other risk factors. And if you are 140/90, we immediately put you on medications. Whereas between 130 and 139, or 80 to 89, we work with people on lifestyle modifications, unless you've already had a heart attack, or you have had a stroke, or you have kidney disease. Then obviously we want your blood pressure to be even lower. What's the best way to take your blood pressure? So this is important to know, is that the way it's measured matters a lot. The numbers are important to actually get a good read on what it is that you're supposed to do. So first of all, you should be sitting in a chair like this gentleman, with your back supported, your feet on the floor, and your arm should be supported on the table, not on your lap. Why does that matter? Because your arm, where the cuff is, needs to be at your heart level. So when you move your hand, your arm will be too low. If you're standing and you raise your arm, it will be too high. Yes, we can do blood pressures with you standing. However, we are measuring according to your seated blood pressure, which is what we most often titrate the blood pressure medications to. The other issue to know is that the size of the cuff needs to fit your arm. And so if you have a very large upper arm, you might need a thigh-size cuff. Most adults in America need a large adult cuff, and any more, the cuffs that you buy in the drugstore will be sort of gauged to fit a average adult and a large adult arm, just because it's so much more common to have that size of cuff. When do you want to measure your blood pressure? Can be early in the morning, can be later in the day. But importantly, if you're on treatment, you want to know what's your blood pressure after you have taken your medications. So what should you do? Last year or 2 years ago, the American Heart Association put together what we call the Life's Essential 8, the 8 things that you should focus on that will help you to live a healthier lifestyle. 1, eating better, lean meats, lots of fruits and vegetables. Fruits and vegetables that are fresh or frozen rather than coming from a can, because anything that's canned or been on the shelf for a long time has salt in it that you don't need. Becoming more active, thinking about where are you getting your activity on an everyday basis. The more we work sitting in front of a computer, the less active we physically are. One key thing is everybody likes to have fitness devices. You don't have to have the most expensive one, but having one is helpful for you to know how much did you actually move today, so that you can look and notice, oh, I haven't moved very often today. I might need to do something else to get my physical activity up. If you smoke, stop. Healthy sleep. That was the most recent addition to this list, is that we don't pay attention to the amount of sleep that we get that is good sleep. Sleep matters. Sleeping is not making you lazy. Sleeping may extend your life. 7 to 9 hours a night is the healthy amount of sleep that we should be getting. Looking at how we live lives and how do we go to bed and what time do we get up on a regular basis. It's not the same as catching up on the weekends when you starve yourself all week of the right amount of sleep. But this is important to also manage blood pressure and also to just generally feel better. Managing your weight, your cholesterol, your blood sugar, and then again, your blood pressure. So I'm going to twist a little bit to this topic, and I want you to look at all of these 4 pictures of these women and think about what do they have in common other than being famous and being fabulous and African American. It is the fact that they all suffered from a hypertensive disorder in pregnancy known as preeclampsia, which landed them in the intensive care unit trying to just bear children, a very normal process for women. And yet for Black women, it becomes life-threatening all too often. We need to understand that, because if you have preeclampsia, the condition actually increases your risk of having heart disease later in life and also continuing to have high blood pressure even after your baby's been delivered. This is what the cause of the pathophysiology of preeclampsia look like. Now, I didn't put this here to go through the whole thing in great detail for you, but I wanted you to see that it is complex, that there are maternal components of this, and there are placental, i.e. the baby, components that are molecular and pathophysiologic that come together to create inflammation and increase the coagulation process so that you get blood clotting in different places where you should not have it. And women who have this have multiple organs affected. It affects the liver, it affects the blood cells, the brain, the heart, the kidneys, the placenta, and ultimately leads to having smaller babies that have additional issues related to the small size. This is a very serious health condition, and it should not be taken lightly. And it is one that we need to be educated about, and we need to educate our young sisters who are looking to have children. Black women are twice as likely as white women to have uncontrolled blood pressure during pregnancy years. And Black and Hispanic women are more likely to die. Yes, I said die from childbirth than are white women. And Black women have the highest rate of hypertension in pregnancy. Think about this. The maternal mortality average in the US is 18 out of 100,000. In white women, it's 13. In Black women, it is 41. Yes, I didn't write that backwards. It's not 14, it is 41. That is huge. Now, here's the other key factor is that most people would assume that that is related to not having access to care or not having finance. The rate for Black women who are educated and working in white-collar jobs is equally elevated above that of white women who are similarly educated and also in higher socioeconomic standards. So there's something happening here that is unique. How do we protect ourselves? Women need to start before pregnancy actually happens. Healthier weight, healthier diet, healthier blood pressures, controlled blood pressures, very important. The Mediterranean diet is a diet that has been shown to be help women during pregnancy who are dealing with elevated blood pressures, and also aspirin as a preventive measure is now being recommended for women who are at high risk for hypertension during pregnancy. There is still some debate about exactly what dose, but it's been shown that a low dose of aspirin is probably very helpful to reducing some of the complications of hypertension in pregnancy and preeclampsia. I'll end with two final slides here. One is this, is to think about what can we do. I use this slide for the academic presentations that I do for doctors and healthcare systems to think about how do we change this. And that is to say that we're all involved. We all have a role to play, is that we are individually a part of many different circles. We are in churches, we are in mosques, we are in social community organizations such as this one. We have our own family groups and our own friend groups. Those are all different circles that we circulate in. Each one of them can be helpful in promoting the conversation and extending the knowledge. Health literacy has been associated with improved outcomes in any disease that you think about. And that health literacy doesn't always necessarily have to come from being in the room simply with your doctor. Facilitating that conversation to happen in every domain is to talk about it at your job, is to think about it within the perspective of what you do and how can you promote a healthier lifestyle from the job that you serve in, is thinking about the environmental needs and how do we support that more broadly. While this is preeclampsia supersedes necessarily just socioeconomic needs, but overall, heart health is very much affected by what we call the social determinants of health. And so we come back to this picture again. What do each one of these women have in common? And you see them popping up, and they are from every domain of life, doing absolutely amazing things. In every case, is they all have hearts that need to be taken care of, and the extent to which they affect their lives, their circle of influence is broad, includes you and I. But more importantly, I left the center circle open because the woman in the middle is you. And you have a job to do. If you only focus on your own life, you will be affecting so many others around you. But if you add to that 2 or 3 that are in your circle, you will be serving the world in a positive fashion. Do your best to take care of your heart. And with that, I will stop and open the floor for questions.
Okay, I'll be reading the questions as they come in through the chat. Okay. There is a question that says, I suffer from high cholesterol. I've been advised to take vitamin D and fish oil supplements to help reduce cholesterol. What is something practical that we can do to reduce it?
Yeah, thank you for the question. So first of all is to know two important pathophysiologic things about cholesterol. One is that the larger component of your cholesterol level is determined by your body's physiology. Your liver makes cholesterol. And so as we think about the mix of dietary influence versus metabolism influence, the metabolism has a much stronger effect than your diet does. Nevertheless, what can you do about your diet? Looking for healthier fats. We all do need some fat in our diet, but looking for unsaturated fat is a much healthier fat for you to eat than the saturated fats that come from fried foods and processed foods. Looking for ways to balance out your diet with fruits and vegetables that are healthier for you. They make you feel fuller, but they also help your body to be more efficient at utilizing the energy that you're eating. If your cholesterol is, above 240, 250, most likely you have a genetic component that is stronger than you will be able to manage just with diet alone. You may have a genetic component that determines that you have what we call familial hypercholesterolemia. 1 in 500 people have that gene, and the control really effectively can only be treated with medications. And we have medications that are very safe, have been around now for nearly 30 years and clearly changed the face of heart disease by being treated with them. So if you need a statin, take a statin. If you don't need a statin, consider changing your diet and adding some exercise, and then looking at, how can you get your body weight down to a healthier weight because you stimulate metabolism with some exercise.
Okay, there's one more question. How do you navigate the topic of BMI in African American women when so many of us want to be what society calls thick?
I love it. We don't have a category in medicine for thick, but I know we want to be thick. It is interesting though that the categories of BMI were developed largely for white women. And the disadvantage of that is that it not only disadvantages Black women, but it disadvantages Asian women and Indian women as well, because our body frames are not exactly the same. And so I am waiting for the data to give us more clarity around what is a BMI that is actually a healthy BMI for Black women. There have been a couple of studies like the Jackson Heart Study and others that have looked at fat-free mass by DEXA scanning and also bone density and bone mass to assess that a little more clearly for Black women. But whereas the standards are 25 to 30 is considered to be overweight, below 25 is considered to be ideal body weight, and above 30 is considered to be, that is for BMI, considered to be obese. And then there are several categories of that. You probably could add two to that in the case of most Black women, but you do have to really think about it, is that African American women really, from a genetic standpoint, represent a very broad perspective of genetic influences. Is that we are not reflective totally of necessarily any one genetic background, whereas, for instance, Asian women from Asian backgrounds are more consistently, about 25% of most African Americans are European in terms of genetic background, which may mean that not every one of us is exactly the same. So looking at fat-free mass is a good way to look at, your weight, and then doing a waist to hip circumference, which is taking a, um, a tape measure around your midsection, right at your belly button, and then across the widest part of your hips, and looking at that ratio may give you an even better assessment of what fits for you.
And we have a lot of questions. Okay. Next question is, if you have a family history of hypertension, what's the best test to ask from your doctor as a preventative measure, regardless of insurance covers it or not?
What is your blood pressure? That is the best test you can get, and you can do it on your own. And keeping a record of your blood pressures over time. Why is that important? Because the earlier you address it, the better it's going to be for all of your organs that are what we call target organs of blood pressure. That is brain, heart, kidneys. So knowing your blood pressure early, particularly if you know that your family has a high risk, as does mine, is knowing your blood pressure and tracking it is the best thing that you can do. Now, once you have that, you want to know from your doctor creatinine. That is the measure of kidney function that we use, and estimated GFR. Those are 3 letters. You don't have to remember what they mean, but they are both measures of kidney function. So when you're talking to your doctor about your blood pressure, you want to know, what is my creatinine? What is my GFR? Am I still in the right range? Because we are also concerned about heart health, because that's where blood pressure is effective on the heart and the brain, cholesterol becomes an important question to ask. Even though cholesterol doesn't raise blood pressure, this is all about protecting you from heart attacks and strokes. So asking that question is your next question to ask.
Okay. And next question is, you mentioned smoking as a risk factor. Does that also include vaping and hookah?
Nicotine is nicotine. Wherever it's coming from, it's a problem. So if you got nicotine in it, it's a problem.
Okay. Should you wait until there are some signs of heart disease before visiting a cardiologist? What baseline tests should be considered to measure heart health if you are proactively visiting a cardiologist to check your heart health?
Yeah. So most people don't need to go to a cardiologist first. You need your primary care doctor on your physical exam, should be doing your blood pressure, should be talking to you. They should be measuring your cholesterol as well. They should be giving you indication about your creatinine, your GFR, your electrolytes. All of that happens at the primary care visit on a yearly basis. So you should make sure you've got a primary care provider who you are seeing every single year, and you're tracking what data comes out of that visit. If during that visit you find that you are having new symptoms that have not had before, and they are suggestive of cardiac disease, then you need the cardiologist next to follow up and do other tests. And a primary care doctor will do an EKG for you for sure if you present with those issues. But one of the key problems is that we don't tell the truth to our doctors in that visit. Are you okay? How are you feeling? Oh, I'm good. And we pass that off. And that's your opportunity to really make your voice heard. I feel tired. I feel more tired today than I felt 6 months ago. I don't know why. I'm trying to lift my grocery bags and go from my car to my house, and I have to stop. Those are big things. Don't miss the opportunity to tell that.
Okay. The next question is, do you recommend any books about heart health, hypertension, cholesterol, specifically for women of color?
Um, well, I was an author in a book that was written particularly for women. It is Taking Care of You, Your Heart Health. It actually covers more than heart health. I have a chapter in that book, but it covers soup to nuts, many different aspects of your health. You can buy that on Amazon. It's not the only book you can get. The other source of information that is excellent to have is going to the American Heart Association webpage. Numerous sources of information there that are all vetted by myself and others who are part of the cardiovascular health community that are really great. They are also culturally sensitive and set up for any different culture to use that information. There are even cookbooks there that serve recipes that are consistent with cultural heritage.
And next question, with so much going on in the world impacting the lack of protection and peace for Black women, does stress and anxiety impact heart health?
Absolutely. Numerous studies have documented that excess stress from, from living, racism, structural racism, work life. A recent study just published a couple of weeks ago looked at particularly Black women and the roles that we serve in taking care of our family members and many of our community members. We tend to be, holding up the atlas of many different circles, and that role in and of itself also increases the risk of having heart disease and having negative outcomes. So it's stress overall. From a pathophysiologic perspective, there are studies that show that that stress turns into increased epinephrine and norepinephrine. Those are neurohormones that also serve to raise blood pressure and also have negative effects on the heart.
Next question is, you spoke about a diet. How much water should you consume that'll help affect your blood pressure and heart health?
Yeah. So drinking water is good for your kidneys. And so you want to have enough water because your dehydration does not serve your kidneys well, and then your kidneys actually promote higher blood pressures. It isn't that water per se lowers blood pressure. The other part about it is to remember drinking more water will make you a little less hungry because it gives you a little more filler in your stomach, which is always of value. So, roughly about 6 to 8 glasses a day is where we need to be considering how much water we're getting. You get water though in a lot of different formats, not just from drinking pure glasses of water per day anyway.
All right, and I'll take one more question. And it says, I have seen in lab results a measurement for kidney functions for African Americans. Is this number more or less accurate than the creatine / GRF?
Yeah, what a great question.
Yeah.
A couple of years ago, this honestly was right after George Floyd's murder, the conversation around the use of race in many of our calculations done in medical science became a prominent issue. As these calculations were developed, they were developed out of large databases that showed when you do statistical measures, things pop out to say this affects the level. And that led investigators at that time to say we should adjust it for race. So if you happen to be Black, then the right number for you is this, but if you are not Black, then the right number is that. It becomes problematic when you say, well, wait a minute, if we are assuming that Blacks have lower numbers, but Blacks still develop heart disease, kidney disease at higher rates, why are we using race as a factor that we would give more leeway for the numbers of GFR when we should be treating them earlier because the right number is the right number? So many of our calculations have now removed race as a factor because it allows us to look beyond just race. And quite honestly, it isn't race that makes things a problem. It is what I call living while Black. living while X. You know, it's the circumstances that you are exposed to and are living in. So if we assume that it is race, that's not something that we can change. The things that we can change, we have to focus on changing. So past 2020, when the National Kidney Foundation and other societies said we should take race out of that, most laboratories have adjusted their equations now. And because a lot of doctors wanted to see the old ones and the new ones, you might see on your lab result both the old GFR calculation and the new one. The new one will say modified GFR, and a normal GFR should be above 60. And so those that are adjusted for race are not the ones you want to look at. You want the modified ones because that's going to be the one that'll be more protective of you and everybody else.
Okay, and that is all the time we have for questions tonight. I will turn it over to our Madam President to close us out. Thank you.
Thank you. Thank you so much, Dr. Nesbitt. This was so informative. Great questions from our audience. I heard a lot of tips that we've heard before, but some of them we've heard before, and it doesn't hurt to be reminded about diet and exercising and knowing our numbers, and above all, not smoking. So thank you for reminding us and also sharing new information with us about things that we can watch out for to protect our heart and to care for our heart. So I hope everyone learned something tonight that you can take away and protect your heart. So on behalf of myself as president of the Dallas Metropolitan Chapter, as well as our first Vice President, Keisha Dillard, in her absence, and Chair Powell of our Health Committee, I want to say thank you to Dr. Nesbitt again for this very informative presentation.